Hello, good evening. Welcome to Cafdil Healthcare on Cafdil TV. My name is Kojo Arthur. Tonight, we're going to talk about diabetes and the eye, the effect of diabetes on our eye. We are live on Facebook, Cafdil Cape Coast, and YouTube, Cafdil EDU. My guest tonight is Dr. Francis Uredu. He's an optometrist at Healthy Eyes Eye Care and Optical Center, Cape Coast. We'll start talking right after this break. Stay with us.
Since time immemorial, God has always communicated himself and his will through various voices. The prophets, the kings, the judges, not forgetting John the Baptist, who was a precursor to Jesus Christ and gave us the will of God. We bring to you Voices from the Valley. This is a program designed by the Conventual Franciscan Friars in Ghana in collaboration with Cafdil TV to bring you in-depth insight in our faith, catechesis, and various Catholic teachings which will help you in your journey as a pilgrim. I know you cannot miss this program, and I highly encourage you that you shouldn't miss this program because it is Voices of God from the valley of prayer and silence. Join us this and every Sunday at 3 p.m. and a repeat on Wednesday at 7:30 p.m. here on Cafdil TV and on our various social media platforms, YouTube, Cafdil EDU, and Facebook, Cafdil Cape Coast. Let us meet and share what God has for us through the Voices from the Valley.
Lord, make me a means of your peace.
Welcome back. If you just joined us, this is Cafdil Healthcare on Cafdil Television. My name is Kojo Arthur, and so tonight, diabetes and the eye. Like I said, you can see this on my table, and so we're going to dive into the effect of diabetes on our eye. Dr. Francis Uredu, Healthy Eyes Eye Care and Optical Center. Good evening.
Good evening, Ron.
How are you?
I'm doing very well.
And both of us are wearing lens. Nice lens.
Yes.
Let me also inform you that my lens that you see was provided by Dr. Francis Reid. So if you also have any problem, you can visit the Eye Care Center, Cape Coast here, and you are going to get a very nice one, just as mine.
Thank you.
All right. So diabetes and the eye.
Okay.
Tell us, how exactly does this diabetes affect the eye?
Okay, so thank you very much, Ron, and I also like to thank Cafdil TV for this opportunity. Diabetes seems to be like taking a whole lot of people as a non-communicable disease, and you cannot talk about diabetes without mentioning eye care, because diabetes usually has a direct effect on our eyes. So whenever you see diabetes, you see something about the eye, and that is why it is very important that today we talk about the eye in relation to diabetes. When we talk about the eye and diabetes, it is basically due to one thing. When you develop diabetes, what happens is that as the blood sugar level continues to increase or stays at an elevated level, it starts to affect the integrity of the blood vessels in our body. And like we all know, the eyeball also needs blood to survive. So there are some tiny blood vessels that moves all the way to the innermost part of the eye, that is the retina. And when you develop diabetes, the walls of the blood vessels will start to deteriorate. It start becoming porous, and then blood will start leaking into the retina, and that is what usually leads to all the various types of diabetic eye diseases. So diabetes and the eye is basically because the elevated blood sugar level affects the integrity of the blood vessels, the retinal blood vessels, causing them to become porous. Therefore, blood can easily leak from the vessels into the retina and then cause several damaging effects to the eye.
Oh, okay. So what are the earlier warning signs that a diabetic patient should never ignore? Because there are some warnings that you may not even know.
Yeah.
So what are those things that we should not ignore when you see that?
Okay, so when it comes to diabetes and the eye, usually at the early stages there is no symptoms. When it starts, you won't feel anything. You have good vision. You'll be going about your normal day-to-day activities. There are even patients who develop diabetic eye diseases and they themselves are not even aware that they have diabetes. So it is through the eye clinic that we're able to detect that you have diabetes. At the early stages, there is no symptoms. Then as it progresses to a certain level, then it will start manifesting in your vision. So usually those who tends to have fluctuating vision, today your vision will be very clear, you can see well at far. Tomorrow the vision will drop. The next day the vision will become clear again. So if you begin to experience this kind of fluctuating vision, then you need to come to the clinic for us to have this diabetes assessment, and then we move on to the eye as well. Aside that too, there are some people who glasses prescription keeps changing. Today he will go to the clinic, will fix glasses, the person is able to see well. By 3-4 months time, the glasses is no more working. We'll do the test and the prescription has changed. When we get these kind of short-term changes in the glasses prescription, it is also a sign that you might be developing the effect of diabetes on the eye. And aside that too, it can also cause some waviness in your vision. Like you are reading, you see the letter T and the bar on top is crooked in a way, the one standing is also bent, like you see some
italic waves.
Exactly, some italic waves in your vision, especially when you are reading. Then you need to come to the clinic for us to see. And then aside that too, you can also see something moving in your vision, as if there's some curtain in your sight. It can also be a sign of or a symptom that you are developing the effect of diabetes on the eye.
So when they come for the eye check, you said through the eye check you get to know whether the person has
diabetes or not.
So it's not that you check for the sugar level separately.
When they come to the eye clinic, in our assessment there are some signs that we see which will suggest that this person is having diabetes. Then we will go ahead and then do the blood sugar test, and then we can even do the glycated hemoglobin HB test, which helps us to see the long-term sugar level that the person has been through, just to confirm the clinical findings that we had with the eye. So usually when you come to the eye clinic, we do the examination. If we see some signs that suggest that you have diabetes, then we'll confirm it by doing the sugar test and all that, just to confirm the ocular signs that we've seen that you have diabetes.
I think I also still have to ask, why are diabetic patients more prone to eye problems compared to those who are not diabetic?
It's basically because of what I explained earlier. Diabetes affects the blood vessels, the walls of the blood vessels. The blood vessels is like the pipe tubes that connect water to our houses. If the tubes start becoming weak and then holes or cracks start forming around it, some of the water will seep out of the tube and then wet the surrounding area or even flood the place. And the same thing happens with diabetes. Those who are diabetic, their blood vessels becomes weak, so blood easily leaks into the eye and then cause problems, as compared to those who are not diabetics.
Oh, okay. So we have heard what we call diabetic retinopathy. What is it, and why is it considered one of the leading causes of blindness?
So I'll use our model to explain that what I was saying. So this is how the inside of the eyeball looks like. So when you come to the clinic, we look through the eye to see the inside. This is what we see. And you can see that within this, you see some lines here, the red and then the blue lines. These are the blood vessels. So the red represent the arteries and the blue represent the veins. So these blood vessels sense blood, oxygen, food to the cells in the retina or the photoreceptors and the other surrounding tissues. So when you develop diabetes, it starts affecting the blood vessels and it starts becoming porous. So blood will start leaking into the eye. Into blood ni bi betumi aba cover tissues ni bi so e bi kura betumi leak with as suspended within the eyeball itself. So once there's leakage of blood and changes start developing on the retina, then we say that you have what we call diabetic retinopathy. So diabetes will cause the blood vessels to become weak, then it will start leaking. And whilst the blood leaks, assuming blood is supposed to come to this part of the eye, then when it got here, it got leaked. It means that all the cells here will not get food, so they are going to die, and it will cause other changes here. So you can even see, sometimes you see white patches, sometimes you see orange patches. I don't want to be too technical, so I want to make it easy. So you can see white patches, orange patches, you can see dots. It's because blood is not getting to where it's supposed to go. Then the cells there will die.
Seen through
it's seen through the eye, and that is why we say that the eye is the window to the body. The eye is the only organ that will allow you to see the blood vessels without cutting. The only organ that will help us to see the blood vessels without cutting is the eye, because the blood vessels are within the eye. It's on it. So when I look inside, like into your eye, I see your blood vessels. So usually if there is something like high cholesterol, sometimes we can even pick it from the eye. Or if you are about to get stroke, those with embolize, we can pick it from the eye when we do the assessment. So eye visit is not just about the eye. So we as doctors, when we are doing this examination, we are not just focusing on the eye. We keep an open mind, so that if there's any other systemic condition that can be picked through the blood vessels, the blood moving around, then we can detect that. So once those changes occurs within the retina, then we say that you have diabetic retinopathy. And it leads to blindness. It is one of the major causes of blindness, because the retina contains the cells that helps us to see. So if there is blood covering them, or if they are not getting food, nutrition to eat and they die, it means when the light enters the eyes, there will be no cells to process it, so you won't be able to see. And that is what makes diabetes one of the leading causes of blindness.
This is very delicate.
Very. When it comes to the eye, it's very delicate. Everything matters, and the eye is such that it needs to be transparent. We don't want any fluid to leak into it or in any way, because it is the retina, for instance, is like the camera. So the light will go and fall on the film inside the eye. So we don't want anything to interfere with the light falling on the film. So if there is any blood, there is any fluid that forms on it, it will have a corresponding effect on our vision.
So that is a retinal.
So that is a diabetic retinopathy. And aside that one, there is another effect of diabetes on the eye, which we call the diabetic macular edema, DME, or diabetic maculopathy. So what happens is that within the retina we have a specific spot. Okay, I think it is here. We have a specific spot here. That is called the macula. So that spot is where majority of the cells for our vision reside. That is where they are concentrated. The cones and the rods, especially the cones. The cones helps more with our vision, daytime vision, and the rod helps more with nighttime vision. So the rods are more at the periphery, and then the cones are at the central part of the macula. So what happens is that when you develop diabetes and then blood starts leaking into the eyes, sometimes fluid will also start coming, and if it happens to enter the macula, then we say that you have diabetic macular edema or diabetic maculopathy. And once it gets to the macula, the vision will change. Sometimes the retinopathy will start, but the vision will not change. But as soon as the macula gets affected, the vision will change, because the macula is the central point for our vision. So once diabetes effect reaches the macula, we treat it as an urgent thing, as a serious thing, because if you don't act fast, the vision will go down permanently. So that is the second effect of diabetes on the eye. And then
so this is the shape of the eye.
Yeah, so this is how the eye is. So we have the cornea at the front here. So when you are looking at something, the light will pass through the cornea, which is the first layer here. Then
so you show it to the camera here.
So the light will pass through the cornea, which is the first layer over here. It is transparent. Then the light will pass through the pupil. So the pupil is like a hole within the iris. When you look in the mirror, you see the black part of the eye. It is what we call the iris. So it is actually brown, but because of shadow falling on it, that is why we see it as black. So within the iris, we have a
there
hole.
are some you could see the brown.
Yeah,
some
that is
have also blue.
Those ones are the white, but we Africans, mostly ours is brown.
So there's
brown.
no black.
No, we don't have black. It can be dark brown, but not black.
And that's if we are not washing.
A shadow na also.
Okay, so we are unable to.
It's a measure straight to say I would say black, but when you sit behind the machine and I examine, I see it as brown. So it's just a shadow that is falling on it, making it.
Then whenever we are feeling,
you are supposed to write brown, not black.
Black. But they also provide black. Then we
no,
black.
It's not supposed to be black. It's supposed to be brown.
Okay.
So the light will pass through the pupil, then fall on the lens. So the lens is behind the pupil. So the lens is also transparent. It is a crystalline glass that is here. So this lens will focus the light on the retina. So within this space is what we call the vitreous cavity, and it is a gel that is here just to keep the eyeball inflated. Senka gel we ni ha odon se mia we ni pe ebetum. But because of this space here, yeah, the gel and egumu, so it is very thick. So it's very thick. That is why it makes the eyeball a bit firm and
so if you feel like itching, if you could see that the eye will be moving.
It's a bit tough because of the gel at the back. So the lens will focus the light on the retina, then the retina will process the image and convert it from picture to electrical impulses. Then it will send it to the brain through the optic nerve. So after the retina has finished its work, it will send the message through the optic nerve to the brain. Then the brain will interpret it as you are seeing a camera, you are seeing a light. So that is how the eye
then
works.
it's very fast.
It happens in nanoseconds. And it is a chemical, it goes through chemical processes, but it is very, very fast. It is more or less instantaneous. It happens
because
as
if
it goes.
you are seeing this and immediately you can see
it goes through so many, even within the brain, it goes through so many processing before the final interpretation will come. Because when you are looking at this image this way, when it enters the brain, it is like this. It turns upside down. When you are looking at this model, when the picture gets to the brain, it turns like this. So the brain will now process it and convert it to this way. So it is a process. That is how it is.
Where if you take this one, this 1, 2, 3, where the lens is being protected by this. This one.
Yeah, exactly.
So it's not easily.
So the lens is within the eyeball, and the lens, there is fluid surrounding it. So it is more or less suspending within it with some ligaments holding it. I say it is just suspending within the eyeball. So that is that
fluid on my eye
the fluid, that one, it doesn't come out of the eye, like it is within. It doesn't come to the surface. The tears, it is produced by the lacrimal glands at the top here.
So we can only see only this.
Yes.
All these are in the head.
Exactly. But when we use the machines, we can see the lens, we can see everything. So when we are doing eye examination, I can see the lens, I can see the vitreous, I can see the retina, and the optic nerve head. If there is any issue, then I can identify.
And the eyeball.
And then this one is represent the gel. So that is sitting within this space over here.
Represent the gel.
The gel.
So where is the eyeball?
So this whole thing is the eyeball. This one is a gel within the vitreous cavity over here.
Hey, and it's very complicated.
That is how it is.
But how do high blood sugar level also lead to cataract and glaucoma in diabetic patients?
Okay, so for cataract, what happens is that when your blood sugar level rises or stays high for an extended period of time, after the processing to glucose, some of them gets further processed to become what we call sorbitol. Sorbitol is a form of sugar within the body. So what happens is that the sorbitol, the excess amount of it will enter the lens. It will get absorbed into the lens, and when that happens, the concentration gradient in the lens becomes more than the fluid around it. So we call something osmosis. When there's a higher concentration gradient, water will move towards it. So water will then move into the lens, and the lens has been made such that it needs to be 100% transparent. So the cells within it are arranged in a regular order. They are arranged in a perfectly regular order. That is why it is transparent. So when sorbitol enters and then it pulls water into the lens, the water will disturb the arrangement of the cells within the lens. And once that distortion happens, cataract follows. So cells are distorted, then it starts becoming cloudy, and that is the beginning of cataract. So when you are diabetic and you don't manage it well, there's a high chances of you developing cataract as compared to the non-diabetic. And if you already develop cataract before becoming diabetic, then the rate of progression of the cataract too will be faster. And that is why diabetes and cataract, like we say, that you need to manage it well.
So the sorbitol tend to the white.
The sorbitol is not the whitish. It is like sugar, and that has entered the lens. So when that happens, the concentration gradient in the lens becomes high. It is like share enam nchine. Or the nchine no gu enam no ho, the concentration gradient in the salt no is higher than in the fish. Into a battery in sheer fish no more. That is how they preserve fish. So in the lens too, when the concentration gradient in the lens becomes high because of the sorbitol na bemuna, it will pull water, the surrounding waters.
I just want to know, the cataract, you see it.
You see it as white. It's because the cells has been disfigured. That is what causes the whiteness to form. They are supposed to be arranged in a specific order. So once you alter it, it will turn white and then grayish and all that. It is basically a manifestation of diabetes.
So I thought it was older adults who normally develop these complications, but are young people with diabetes also at risk of eye complications? Yeah,
young people with diabetes are also at risk. In fact, everyone who has been diagnosed of diabetes is at risk of developing these complications of diabetes. That is why we advise that once you are diagnosed of diabetes, you need to make sure that the eye clinic becomes your next to go to place, or you need to get an eye doctor friend so that he can monitor some of these changes, because when we pick some of these changes early, then we can find solution to it, so that we don't wait for it to become worse. You mentioned about glaucoma, how diabetes also causes glaucoma. What happens is that when blood starts leaking within the retina and some of the cells are not getting blood and oxygen and all that, the brain will tell the eye that the blood coming to you is small, so produce more blood vessels. That is what we call neovascularization. So new blood vessels will start forming within the eyeball, just to replace the ones that are getting broken. But the unfortunate thing is that the new blood vessels are not strong. They are rather weak, so they rather come to even cause more problem. Because they are weak, they rather leak more. They leak more and then cause more blood to form within the eye. So some of the new blood vessels will move from the retina all the way to the iris, to the iris here, until they will move from the retina all the way to the iris, and then block the channel that allows some of the excess water in the eye to exit. So when that happens, more fluid will be retained in the eye and the eye pressure will go up. And when the eye pressure goes up, then glaucoma will come in. So the new blood vessel that forms within the eye as a result of the retinopathies, when they migrate to the iris, they will block the channels that light passes through, that the fluid passes through to exit the eye, and cause the eye pressures to increase, and that is what leads to the glaucoma in diabetics.
All right, you're still watching Cafdil Healthcare on Cafdil TV. We are discussing diabetes and the eye. My guest is Dr. Francis Redu. We're going for a short break. When we come back, I will ask how often should those diabetic patients get an eye examination, and we'll continue. Follow us on Facebook and YouTube. Stay with us.
Since time immemorial, God has always communicated himself and his will through various voices: the prophets, the kings, the judges, not forgetting John the Baptist, who was a precursor to Jesus Christ and gave us the will of God. We bring to you Voices from the Valley. This is a program designed by the Conventual Franciscan Friars in Ghana in collaboration with Cafdil TV to bring you in-depth insight in our faith, catechesis, and various Catholic teachings which will help you in your journey as a pilgrim. I know you cannot miss this program, and I highly encourage you that you shouldn't miss this program, because it is Voices of God from the valley of prayer and silence.
Join us this and every Sunday at 3 p.m. and a repeat on Wednesday at 7:30 p.m.
here on Cafdil TV and on our various social media platforms: YouTube, Cafdil EDU, and Facebook, Cafdil Cape Coast. Let us meet and share what God has for us through the Voices from the Valley.
Lord, make me a means of your peace.
Welcome back from the break. You're still watching Cafdil Healthcare on Cafdil TV, and we are discussing diabetes and the eye. With me here is Dr. Francis Redu from Healthy Eyes Eye Care and Optical Center, Cape Coast. Doc, so those diabetic patients, how often should they get their eye examination, and what does the exam typically involve?
Okay, so those who are diabetics, the first thing you need to do once you are informed you are diabetic, you need to visit the eye clinic for examination. And for the reviews, it depends on what we find as in the first visit. So when we examine the eye and we see some small changes, we can say that let's do the review 6 months, every 6 months, or if there's no changes, we can schedule it every year. And there are sometimes you see that there's blood coming in, there's these changes, then we can say that we are doing the reviews every 2 months or every 3 months. So when it comes to the review, it depends on your current state in terms of the health of the eye. But once you have been informed that you have diabetes, you need to visit an eye clinic. And then when the doctor examines based on his findings, then he can draw a plan for you as to when to come for your reviews and all that. And when you come to the eye clinic, every patient who is diabetic, there's one test that we do for them basically. That is the dilated fundus exams. Every diabetic patient needs to go through that test. What that basically means is that we will install some eye drop on your eye just to open up your pupils. When we open up your pupils, then we're able to see the retina very well. You can see that the pupil is a small hole within the eye. When a light passes through to get to the back. So when we are looking at the back through the pupil, sometimes it's a bit difficult to see all around the retina. So we will install the medication on the eye, and then this small hole will open up to become
is it elastic?
It is elastic. It is just an aperture within the iris. Into whenever contract but down. Na so that we get more view of the retina. So in that way, if there is any hemorrhage here, we will see it. If it is here, we will see it. If it is here, we will see it. But if you don't do the dilation, your view of the back will be a bit limited. So every diabetic patient, we install that drop. You wait about an hour for the medicine to open up the pupils. Then we examine the retina.
So that is different from someone coming for eye examination.
Someone coming in for eye examination, some of them, sometimes their pupils is large, so we don't even have to install the drop. So we can just look through and see. But by convention, every diabetic patient, whether the pupil is large or not, you need to do the dilated fundus exams
for an hour.
For an hour, just to be able to map the whole retina, top, down, left, right, so that if there's any retinopathies, any macular changes, anything going on, you will be able to detect it. So that is the most important test aside the vision and the other tests that we are going to conduct. And it needs to be done on a periodic basis depending on the state of the retina at the moment.
So even if when the patient is or feels normal, the disease can be picked early.
It can be picked early. You don't have to wait for the signs to set in. Once you hear you are diabetic, the eye clinic should be a regular place that you need to visit. You don't have to wait for the signs, because when you wait before the signs will manifest, then it means it has gotten to stage 3, stage 4, and that one it is a bit difficult controlling. So you don't have to wait for the signs to set in. Once you know that you are diabetic, you make sure that you visit the eye clinic on a regular basis, and then you'll be given some scheduled appointments to follow so that we can monitor you appropriately.
But is it also possible that you diabetic on your eye problem?
It is also possible depending on the duration of when you're diabetes. No, that is number one. Obia when you're diabetes just 1 year, effect will not be like someone who has been diabetic for 5 years, because the longer duration of becoming diabetic, the more likelihood that you are going to get these conditions. And aside that one too, the management of the sugar level. how well you manage the sugar level will also influence the integrity of your retina. If you manage the sugar level very well, it doesn't jump into the 10s, the 20s, 30s, 40s.
The sugar level, the actual sugar, I mean the normal sugar level.
We don't want it to be above 7, across 8, that is for the fasting. But once it crosses to 10, 11, 12, then it means the sugar level is high. Across at least 7 is manageable. But there are some people, they know they are diabetics, but they don't follow their treatment. They will be visiting places. Some will go for some things which I don't want to mention. There's some popular church that sells some drinks to their members that it will cure some of these diseases, and it rather worsens it. So when they go for those items, they leave their diabetic medications and rely on them, and by the time they realize the sugar has gotten so high and then cause so much damage to the eye.
Man pain be, I mean, not a diabetes. Okay, the may be until ordinary do no go. So never coffers and unfair do now. No, I would force and was someone to fetch up as if the person is sick.
That is the danger we are in now. Most of our patients, especially our mothers, they don't adhere to the treatment for these chronic conditions like hypertension, diabetes, because they are searching for quick solution, but these conditions are chronic. We don't treat them per se, we manage it. So if you leave your medications, the sugar level will go high, it will affect the blood vessels, and the effects will manifest in your vision.
So let's see what lifestyle habits, being diet, being exercise, being medication, help protect the eye of diabetic patients.
So to begin with that, there's one we call something the ABCs for diabetic patients. So the A represents the A1C, that is the glycated hemoglobin. We want you to control your sugar level well. That is the first and the most important thing. So you need to probably see a dietitian to advise you on how to eat and all that. Sometimes when we talk about sugar level, people think it is about putting in sugar into your cocoa, putting in sugar into your tea. So they will stop those ones and they think they are doing so well. It is not like that. Any food that contains carbohydrates, when it digests, it becomes glucose, it becomes sugar within your blood. So coconut one fat sugar in guma. The cocoa itself contains carbohydrates, so there is sugar. So you need to make sure that
you don't taste it.
Just that you don't taste it, but it will break down to become sugar. So your diet needs to be less of the carbohydrates and more of the raw veggies, the vegetables. So if it is fufu that you are eating, the fufu itself should be a bit small, but you add more soup just to fill your stomach. If it is yam that you are eating, small yam but more stew, so that you feel full.
So
that is
too naked to me.
That is a way.
My brothers and you,
if we want to manage diabetes, well, that is it. If you rely on just the medications, it will be difficult for you. It will be difficult. We'll be increasing the dosages, increasing. But if you add dietary changes to it, it's helpful. Then the B represents blood pressure. You need to maintain your blood pressure well. One thing is that diabetes and hypertension are like cousins. Once you see one, the other one will just be standing by. So once you are diabetic, you need to make sure that even if you are not hypertensive, you manage it well, you exercise and all that, so that you don't develop hypertension. Then the C represents cholesterol. You need to make sure that you control your blood cholesterol. So once you are diabetic, usually the doctor will let you do the BP, the cholesterol, lipid profile, just to see your cholesterol level, so that if it is high, medications will be given to you to reduce the cholesterol. You also check your diet, you reduce the fatty meat and all that, just to help control the cholesterol. And then aside that one too, you need to make sure that you exercise more, you drink more water. These are some of the basic things that we can do, whether you are diabetic or not, just to try and then prevent the onset of these retinal changes in our eyes.
Let me take you back to the diabetic retinopathy.
Okay.
If you diagnose that, what treatment options are available?
Okay, so we have several treatment options. Some include eye injections, some to include laser surgeries, and then sometimes to normal surgery depending on the type. So the first one is the eye injections. So when we see that, usually before we will go in for injection, then it means that we've seen that there is new blood vessels forming within the eye. That is the neovascularization or the proliferative diabetic retinopathy. Once we see that there is new blood vessels forming within the retina, we will have to inject some medication called the anti-VEGF. The anti-VEGF will prevent new blood vessels from forming, because I explained earlier that the new blood vessels are tiny and they are not strong, so they rather leak more blood into the eye, so we don't want them. So we give anti-VEGF injections directly into the eye so that it will prevent new blood vessels from forming.
So the person will be...
Yeah, it's just through the top, not the center, the white part. So the injection will be given through that.
This is not easy. It wouldn't be easy.
But some medications will be like topical anesthesia will be given just to numb it a little, so you won't feel so much pain.
Even the last one, the last time I came, you just thought, look how I suffered.
But once the new blood vessels forms, we give the anti-VEGF injections. And sometimes too, when there is diabetic macular edema, that is fluid builds up at the macula, we can also give injections of steroids, anti-inflammatory injections, just to reduce the inflammation at the macula. It will help absorb some of the fluid from the retina or from the macula. So basically these are the two main injections. That's the anti-VEGF and then the steroids, just to control the effects of diabetic retinopathy. And then we also have the laser approach. With the laser approach, what we do is that we use a special laser light to seal off the leaking vessels. Into it is a pipe na water was for the journey we aba now omotra end no more sealing. That is what we do. So we use laser to seal off, to burn the leaking vessels. And then aside that too, depending on the stage, we can also use laser to intentionally destroy the cells at the periphery. Because of the diabetic retinopathy, now limited blood is coming to the eye. So we want the blood to go to only the important places. We don't want the small blood or nutrients to go to all the sides. So the side that is not too useful for our central vision, we use laser to burn them. And that is
but is it also not going to give you maybe problems later?
It won't. The problem will be like your night vision, that will go down a little bit. But we are interested in your central vision, daytime vision. And only now you use no more.
But this also brings me something. Some people, they don't see well during the day, but they see well during the night.
Sometimes it is because they have cataracts. Sometimes when you have nuclear cataracts, that is a lens no so no infin. It is a infin. The pupil no, in the daytime the pupil becomes small. In Tabanesana, the small amount of light that enters will meet the cataracts at the central part. So light will not get to the back wall. But in the evening, because of the darkness, your pupil will open up. So more light will enter until they can bypass the cataract. So because the pupils are widely open, they can pass through the periphery and get to the retina for you to see.
Lack of knowledge.
So that is how most of them is. And to be dilated fundus exams na me kind. Oba ye dey draw beso when you know so people no. For the average person, we are vision here black a for a day, then it comes back to normal. But those with central lens opacities and a cataract, they draw no good it rather makes their vision clear because now the pupil has opened, so light can bypass the central opacity. Cataract never in fin, light can now pass through the corners, so they're able to see well. So some of them will even tell your doctor, a drone now do good, me pay trauma me na me nkotobi. Just like that drug, every day we are not the good. So
is it correct?
No, that drug we don't give it out to patients because of the other side effects. It can have an effect on your heart and your blood vessels and all that. So we use it in-house, like in the clinic. We don't give it out to patients. So that is how it is.
So those of us who have been calling people which and which, that is the explanation. So stop doing that.
That is the main thing.
So early treatment also sometimes they are very good. I'm not saying sometimes. It's good. So does it reverse the damage or only prevent it from getting worse?
It's mostly, it doesn't reverse the damage. It rather prevents it from getting worse. For instance, if we see that blood is leaking, the one that has leaked to cover the surrounding cells, you can't clean it, basically. So you need to seal it so that it doesn't extend further to the cells around it. And sometimes the body also has its own way of cleaning up the mess within it. So if you are fortunate, the eye itself will put in a mechanism to clear those blood from the eye, and then you'll be fine. So early management is very, very important when it comes to the effect of diabetes on the eye and the retinopathies. That is why we advise that you visit the clinic often once you are diabetic, so that when we see new vessels forming, quickly we give injections to stop it. When we see there's a swell going on, we give injections to stop it. And one thing is that most of these diabetes effects on the eye, we don't use eye drops to manage them because it is within the eyeball deep. So we don't use eye drops. So most often it is injections. It is injections.
But the eye drop, where does it doesn't go deep, right? The
eye drop doesn't usually get to the retina. Even if it will get there, it will be just a small fraction of it. It is basically to treat the surface and then up to the lens, up to the side. That is where we use the eye drop. So the surface up to the lens. Then from here coming downwards, we can give injections, and sometimes we can give tablets, capsules, when we see those changes.
So the blood sugar control, how is it important in managing diabetic eye disease?
It is the first and the most important management in diabetic eye disease management. So when you come to the clinic and you have these diabetes effects, the first thing the doctor will tell you is to control the sugar well. Because if we give injections and the blood sugar still stays high, the other blood vessels will also get destroyed. Then it's like we are doing cos 90 work. So the most important thing is control the blood sugar to a very optimal level. Then we can come in and also control the effects of the diabetes on the eye.
All right, so there are certain things certainly the diabetic patient should do to reduce the risk of going blind. What are those things?
So the first thing is to make sure that you control the sugar well, cholesterol, hypertension. You make sure you manage it well. Then the next important thing is you make sure that you visit the eye clinic on a regular basis. That is very, very important, because all these changes, you yourself, you won't see it until it gets to the advanced stage. So if you don't visit the clinic for us to detect some of these things, you won't know. And by the time it manifests, your vision is almost going blind. There was a patient I had, and there was a pool of blood within here. Like it is like a canoe shape pool of blood within it because of diabetes. And he wasn't aware that he's diabetic too. That is unfortunate.
He was not feeling anything.
He wasn't feeling anything. So when that blood formed, it blocked the vision. So that is what brought him to the clinic.
Okay.
That doctor, all of a sudden, one eye cannot see well. So when we did the examination, then we found that there's a pool of blood over there. And we further did the blood sugar test, and we found out he's diabetic, and he wasn't aware. And that is why the one eye test can save you a whole lot of from a whole lot of issues. So it's not just about checking your eyes, it is also about having a deeper look into your general health and well-being. And that is why we say that the eye is the window to the body. So some of these vascular changes, hypertension changes, we see it through the eye.
So when it comes to this diabetes and the eye, certainly there are misconceptions surrounding it. Have you heard some, or you have some that you would want to debunk?
Okay, so one is the cataract. Sometimes people, when the cataract forms as a result of diabetes, people will say it's cocoa and all that. It's never cocoa. And it is basically because...
But can cocoa cause that?
Cocoa doesn't cause cataracts. It doesn't cause... Almost when I hear some of these things, it's I just laugh over them, because throughout my education, all the books we've studied and all that, there is nowhere that we've mentioned cocoa causing eye issues. If your eyes are itching you, it is not cocoa, it is allergies. Something irritating has got into your eye, the eye is responding to them. But most other people will attribute it to cocoa. Which is not the case.
Cocoa. I ain't so for honestly, cocoa.
And mostly with our herbal system, it's good. I'm for it. But some of them, because it is more or less a business thing, they want to attribute everything to the drug they are selling, and that is what why we need regulation to that practice, because you can't tell me that one medicine can solve about 100 conditions all together. It is like you are casting the net wide so that you get more people. It's the white people, their drugs. If it is diabetes, you have drugs for diabetes. Hypertension, we have it. But with our system, it's like one drug, you mention all the diseases, so that if you are in the car, at least you have one of them and then you buy it. And that is why we need regulation in some of these things, because it has negative effects on the people. They will buy them and leave their prescribed medications and rather get their condition worse. Then you see them being rushed to the emergency, that their sugar level is around 50, 60, they are almost dying. And it's a burden to our health system. We spend so much on them due to some of these things. So these are one of the misconceptions. And then also, if you get diabetic retinopathy, some people will say that it means you are going to go blind. It is never the case. If we see it early, we can stop it, or at least slow down the rate of progression. That is depending on the time that we see it. And with my practice, I've seen several patients with diabetes that we've managed, and they are doing well. But those who come in late, usually there's nothing much you can do to save the eye. If there's so much blood all over the retina, you can't go to clean all the blood. By that time, the cells will even be dead. And once the cells dies, you can't bring it back. So it depends on how early we see it. Then we can give you the appropriate management to it.
So let's say that if a patient already has a vision loss from diabetes, what support or rehabilitation options exist for them?
Okay, so if the vision loss is due to the cataract, then we have surgery that can be done to remove the cataract lens, and then we put in a new transparent artificial lens for you to see.
That artificial will also let you see?
It will let you see. That is the cataract surgery.
That
one is prosthetic eye, and it doesn't see. It is like this plastic eye. Mostly you say you two when you are walking around, everyone will see that one eye is not there. It's cosmetically, it is not appealing. So we'll take the measurement of the other eye, and then we'll use plastic to form the same shape. Draw blood vessels on it, and then you
that
fix
one not
it.
Be replaced by?
No. That one is just plastic like this, so you don't see with it.
I mean the eye itself. So then you wanna send away to if you want to move even
like this one.
And the one is the lens. The artificial
no. The artificial lens. This one is to be placed within the eyeball. It's suspended within the eyeball. But usually those without eye, although when you have severe eye infection, say that the eyeball is spot. We don't want the infection to spread to the brain, so we remove the whole eyeball from there. Then it will leave a hole there. Until, in order not to leave it just like that, we fix a plastic eye there so that it will appear as if there's an eyeball there.
That one is obvious. When you see them, you could see it.
But sometimes it depends on how it is done. Some can be done such that you will notice that it is plastic that is there.
But it's very white too.
There are some you will notice it. Also there are, if you are, it is already made. One will look bigger than the other. But if we take the measurement, we take the color of the other eye and we design the same, so you might not even notice.
Is it expensive?
Not too expensive. Just that in Ghana so far it's only Kolebu that have a unit that that's the only place I know of. That's those things.
Does it cover?
I'm not very sure about that. I'm not sure.
Will it be like 2,000 Ghana cedis?
2,000. I can't be specific. I can't be sure about that. But it is there. So if the diabetes causes cataract, we can remove it and help with it. But if there is blood, the retinopathies, maculopathies, such that nothing can be done to save the vision, then we say that you have visual impairment or low vision. Then that one, we have a doctor who specializes in low vision. We'll refer you to see that doctor. And when it comes to low vision, that is when we use the magnifiers. Because it makes it so big to see. We also have
microscope.
We also have microscope there. We have the electronic magnifiers too. And then I say phone camera into the text, and so a capture pen and just for you to see well. So that falls within the discipline of a low vision eye specialist.
Right. But is it getting people to come for regular eye screening is a big challenge in Ghana?
Yeah.
So apart from that, what other challenges do you face?
Okay, so number one, like we said, is people coming in. Our culture has been made such that we see hospital as solving problems. So if you feel you don't have any problem, you don't go to hospital.
And we hear some people about 3 years in Mungo hospital.
And they think it is not the best. If we have good systems in place, your workplace, they should force you to go for annual checkup. And then one other thing too happens to be with the cost. Now cost of living is a bit high, so if I don't have any problem, why should I go to hospital, pay consultation, pay this, that is also one of the challenges that we have, and also the patient's waiting time. You want to go for just checkup and you can sit there for the whole day. It also discourages people, but in all, we need to look at it from this direction. You can do all that you are doing now because you are in good health, because you can see. If you go blind today, will you be able to go to work? Will you be able to go to farm? Will you be able to do all that you want to do? So you need to deliberately set a day aside so that you just go and then have an eye assessment. And with the eye, it doesn't even take long. If you come to Healthy Eyes, within a few minutes, we'll be done with the assessment and then we get you the results. So we need to make it a deliberate effort, and know that your health is your wealth, and no one will do that for you unless you yourself, you deliberately make a decision. That there are some people, they say that every September or on their birthdays, they will go for full medical screening. Every year, once the birthday is super, on himself time also for checkup. So you can also find a way to institute something like that, so that some of these issues can be seen early and then management given to address them.
All right, our time is up, and so what is your strongest advice to every diabetic patient watching us right now?
Okay, so my advice to you is that make sure that you control the sugar well. You follow the instructions your general practitioner or doctors will give you, because that is the first and the most important thing when it comes to diabetes and the eye. You make sure you take your medications religiously. Next, you need to make sure that you come to the eye clinic for comprehensive eye examination, not just a small corner. You make sure that you come to a good eye clinic so that we can examine the eye, look at the retina to see that everything is fine. If there is any changes, then we can give you help. So if you are diabetic, it doesn't mean you are going to go blind or you are going to die. It all depends on you, how well you manage it, and then how well you visit the eye clinic and the general hospital for assessment. So let's make sure that we do at least these two things, and then we will be fine with without any complications due to diabetes.
Dr. Francis Redu, optometrist from Healthy Eye Care and Optical Center, Cape Coast. Thank you so much for your time.
So we are at Pedu Junction.
Pedu Junction,
just adjacent to the Total Filling Station, where the University of Education, Uniba Credit Union, people are that same story building on top. So anyone can reach out to us, and then we will be able to help.
Would you mind telling us your number?
Okay, so you can contact me on 0546 036 17. So 0546 30 36 17.
All right. All right. Thank you so much for your time. Thank you to all the crew, Millicent, and my brothers. And thanks for watching. My name is Kojo Arthur. Same time next week. Good night.